And we are live. Wendy Knoops, how are you? Thank you very much for joining us. You are a GP up in Scotland. You are a menopause doctor as well, and you've been doing this for quite some length of time. What sparked your sort of interest in menopause and women's health?
So very, very early on, back in medical school, I knew I wanted to focus on women's health, but women's health in a community setting, so a primary care setting, and starting off in general practice. But general practice, you do get to see a lot of women's health, but a lot of other medical conditions too. And my focus has been very much about the well-being of women. Understanding how their medical condition impacts on their day-to-day lives, really. So understanding their particularly hormonal health, with work, with careers, with families, relationships, etc. So I ended up doing a lot of my time in the NHS in sexual health clinics, so sexual and reproductive health, which is basically community gynecology work. And as part of that's menopause and perimenopause included in women's hormonal health. So that's always been something that has been within work. But more recently, I think there's been such a demand for support for menopause and perimenopause because it's such a struggle to get access to NHS services for a lot of women. So hence the increase, I guess, in the amount of work that I do and the support to provide.
Yep, absolutely. And one of the things that women always find very, very confusing when they're starting off in this sort of perimenopause phase is, their periods are all over the place. They're heavy, they're light, they're disappearing, they're starting, they're stopping, they're going everywhere. And they don't know, A, when they should start or if they need to start HRT, and B, that if their periods or if they go on HRT, what they should be doing about contraception. So that is the main thrust of our conversation today. So when people do start to experience that sort of change in their periods and their cycles, do you find that they often just think, oh, well, it's too late for me, I don't need contraception now?
Oh, yes. That's why I keep harping on about contraception, how important that is. I mean, that's my interest, is contraception. But I think women forget, particularly in their 40s, they think, we hear all about fertility rates declining, how, I honestly, I'd be rich if I had, a pound for everyone who told me this, that, surely I couldn't, I thought I'd risk it, I wouldn't get pregnant, in mid-40s, for example. So, and then having to tell them at that point when they have an unplanned pregnancy is very difficult because you can't undo that. So a lot of what I want to say today is that just because women have irregular periods or menopausal symptoms does not mean that contraception should be ignored. It should be looked at in addition to HRT. So you'd want to look at the contraceptive component as well. So I'm going to come back to all that in a second, but one of the questions that you mentioned was, well, I'm getting some symptoms, my periods are starting to become a little bit irregular, maybe a bit heavier. So should I be thinking about HRT? And at that point, are you on a contraceptive method and what do you do about that? So there's a lot to talk about for that, because the way I would look at it are kind of three factors. And it's very individual. So it's not that I can say, well, Fiona, what works for you will work for me. And that I think women also find challenging, because then how can they do that assessment? And that's when I say you need to speak to a healthcare professional to help you. But one of the factors is age. So what age are you when you're experiencing these symptoms and when you are having sort of erratic periods and irregular periods? So has this been all your life? Or are you starting now to have these symptoms and issues at a younger age than what we would consider like the natural age for it to happen? So under the age of 45 or even under the age of 40. That's very relevant, because if you're young, as you know, that that will have implications on health. So we will be thinking much sooner about HRT if women start having these problems earlier. But if you're between 45 and 55, which is the kind of natural age, and I say natural because not everybody fits into that category, then it becomes a personal decision, and it depends on the symptoms specifically and not just the age. And then if you're over 55, then it's about, do we need to look at anything else? Is this normal menstruation still, or is there something else going on? So the second bit are the symptoms. So are these classical menopausal symptoms in the perimenopause, and how severe are they, and how are they affecting you? So it may be something that you only have 2 or 3 symptoms, but it's affecting your quality of life quite significantly. So you may get cognitive dysfunction, which then leads to problems for your work, or you may have problems with vasomotor, so hot flushes, night sweats, and you don't sleep, and therefore you can't function during the day because you have no energy, and you can't look after the family or whatever it is. So it depends on the symptoms and how severe they are. And I would say if you've got symptoms that are quite debilitating or affecting you and your quality of life, then yes, definitely look at HRT at that point. Versus some women who may have very early perimenopause and very mild symptoms, and some women don't have any problems. Do you really need to look at HRT or maybe something else in the meantime? And then it's about the third factor, I would say, it's about the timing of those symptoms. So it's about, are these symptoms happening just premenstrually, or are they happening at random times? Because is there a history of premenstrual syndrome or PMDD, and do we need to look at that slightly differently, same treatments, but slightly differently, because that can get exacerbated in perimenopause. So those are the kind of 3 things I would look at first to assess.
Yeah, the PMDD is a very difficult one, isn't it? Managing that one can be very fraught. All right, so we've decided then, okay, let's say that our symptoms are problematic, and they are giving us distress, and we're probably thinking that we should go on HRT, but we're also sort of in that early 40s age group. So let's address how we would handle the contraception side of it first. Then we can move on to the HRT side, or how they work symbiotically together. So what do you do when you're looking at this 42-year-old woman who says, oh God, I really don't want to have another child, but I think I should go on HRT. And I don't need contraception. How do you tell them, oh my God, no, actually you do?
So very much if she's still having periods, we have to discuss that although erratic cycles does mean that ovulation and fertility is unpredictable, but you could have random ovulation. So it's much easier to have regular cycles, because then you can predict roughly when your fertile days are. But when you have irregular cycles, it's very unpredictable. It usually happens about 2 weeks before your next period. But if you're in perimenopause, you could have what we call anovulatory cycles as well. So not every cycle you could have ovulation, and it can be very sporadic and unpredictable. So I would explain that, it's actually quite, to put it in a way, a dangerous time, because you don't know what's going on with your ovulation, and you don't know when you're fertile and when you're not fertile. So the best thing to do is to make sure you are covered if you definitely don't want to be pregnant, and definitely have that contraceptive method backing you up until you no longer require that. So a lot of the questions then are, but I don't want to be on a contraceptive, or how long do I need to be on it? I don't fancy taking this forever, or I have had problems with contraceptives in the past, and then it becomes a discussion about what the best method is. Just to highlight about because women do ask, surely I don't need contraception. You will need contraception. If you're under 50, you need contraception at least 2 years after your last menstrual bleed. So let's say you stop bleeding naturally under 50, you still need a contraceptive method or something to cover you for a further 2 years. If you're over 50, it's only 1 year. But if you're on a method that's affecting your bleeding, that complicates things because that masks your natural bleeding. So if we're just sticking with natural bleeding just now, a 42-year-old lady who's got erratic cycles, so in the perimenopause, and she's not using any contraception, and she doesn't continue doesn't start contraception, she doesn't want to, and she's using nothing, which brings my anxiety back, then we'd have to go back to square one and go through all the different options. But let's say she decides she wants to go for barrier methods, condoms, then she could apply the same rule. She may not be sexually active as well, and that's fine. She could use that rule, the 2 year and the 1 year rule. But as soon as you start introducing hormonal contraceptives, we get a very confusing picture for women.
Yeah, let me just ask you a question about that, because that's the other thing. You might think, well, if I've been on the pill for years, and how do I know that whether or not I've actually been through menopause?
Yeah, exactly. So if this was a lady not on any contraception, we'd go through the different methods and what I would advise for women around that age group. And actually for healthcare professionals, I can't emphasize enough the FSRH guideline for women over 40 on using contraceptive methods. So that's the Faculty of Sexual Reproductive Health. That's for professionals. But and it is to go through the different sort of methods with them. So we have combined methods, which are estrogen, progestogen, so they're synthetic. And so when you're saying I've been on a pill all this time, I'm assuming you're meaning a combined pill, because that's what most women mean. But so combined methods are not just pills. We've got patches and we've got vaginal rings. And then we have progestogen only ones, which are the progestogen only pill. We have the progestogen implant, we have the injection, and then we have hormonal coils. And then you've got non-hormonal methods. So you've got a copper coil, and then barrier methods, etc., and sterilisation, which is obviously much more permanent than any of the other methods. So when you're on a pill, it depends. So let's say she's now come and she says, I've been on a pill all my reproductive life. It's distinguishing which pill she's been on. So has she been on a combined pill, or has she been on a progestogen only pill? Because both of them will mask menstrual bleeding. So some women will have regular bleeding with a progestogen only pill. Some women will have no bleeding with that. And some women will have very erratic bleeding, disruptive bleeding with it. While with a combined method, you can have the traditional kind of way of taking it where you have a regular bleed, but it's a withdrawal bleed. So it's not your own menstrual kind of cycle. It's not your own hormones that are controlling that. It's actually a withdrawal bleed from stopping those pills to allow the lining to shed. But nowadays we tend to say to women to take combined pills continuous and only have a withdrawal bleed or have a pill-free 4 days when you have a bleed. So again, women will think, oh well, surely I've stopped bleeding. I must be fine. Maybe am I at that age? How can you tell? Well, it's the pill. So as soon as you've got a hormonal method, you don't know, is the point. So your question is very valid about, well, how will I ever know? And on a combined method, you won't know unless you actually stop the method and allow your own body's hormones to show you what's happening. Now, I wouldn't recommend that personally. because
them was the contraception, and then you're just going off them to see whether or not you're still actually likely to get
it's like, oh, and so then you could get pregnant and you get your symptoms. So, so I think that's one of the worst things to do. And we laugh about it, Fiona, but actually that's what a lot of women get told. Stop the pill at age 50. Because obviously we don't want to continue. That's our guideline in our guidelines, and that's the advice. We stop combined methods by the time we're 50 because our risks increase. Actually, it could be potentially more harmful to continue that method over the age of 50. So the risks kind of outweigh the benefits. But yeah, it becomes really difficult to then tell a patient or a woman, stop your pill, and then find out, within a few months that she's actually got quite significant debilitating symptoms, plus she's still sexually active. So there are things we can do about that, but what I would recommend on a combined method is that, yes, you can continue on till you're 50, but I would do a lower dose to reduce your risk as much as possible. Or you can look at changing over sooner, before the age of 50, to a progestogen-only method or a copper coil.
Yeah.
So that would be my advice if you're on a combined pill. It's
or
different.
A Mirena coil? What about a Mirena coil as opposed to a copper coil? So at least you've got your HRT component and your
yes
together.
So the Mirena coil is the progestogen method. So so if she changes over to a Mirena, that's fine because that's a progestogen method. So my advice would be then to try and change this sooner, so you could then look at what needs adjusted from an HRT point of view, which will be the next step as well to look at. So when you're on a progestogen only method, if you're not on HRT, then it becomes easier to try and work out because you can do a blood test. And that blood test can give us a good indication of whether you're postmenopause. It's not 100% accurate, but it gives us a ballpark figure. Oh, well, yes, you're probably now postmenopausal.
Yeah, so basically, if you're not taking any estrogen, then you'll still be able to see that your follicle stimulating hormone is way up here. I think my GP described it as in his bed. I'll do this in my best Australian accent. Jesus Christ, talk about trying to flog a dead horse. That was pretty much how he described my follicle stimulating hormone when I went back to Australia 10 years ago. And so basically what you'll be able to see then that the estrogens drop, the follicle stimulating hormone is way higher than it should be, and you'll have at least a vague snapshot of what's going on.
Yes, you have exactly. That's exactly a vague snapshot of what's going on. And then you can apply the same rule if you're under 50, 2 years waiting to stop your contraceptive method, and over 50, it's a year. I don't advocate testing it in your 40s because most women will probably not be postmenopause around that time. It's probably best waiting till you're in your 50s. But again, you don't have to. You could just continue that method till you're 55. So that's our cutoff point when we say women no longer require contraception is the age of 55. So you could continue your contraceptive method for contraception. Bear in mind, contraceptive methods are used for numerous other things. But if it's just for contraception, it's until the age of 55. So you don't need to do blood testing. But if you're desperate to come off that for whatever reason, then you can do that on a progestogen method. Yeah. Obviously, if you've got your copper coil, then you've got your natural bleeding to tell you.
Yeah, nobody ever discussed contraception with me, I have to say. I guess maybe they thought I was so snappy that my husband wouldn't dare come near me for any reason. So it's like it was a moot point. No one's going anywhere near her. So
I have no idea what they think. They may be very focused on the menopausal symptoms, and then along that comes libido and sexual health and sexual function, and they may just wrongly assume that women in perimenopause and menopause are not sexually active. When you ask the question, you'd be surprised. Perhaps if you hadn't thought of that. So I would always want to know if somebody's sexually active. Now, they may not be, because there are significant vaginal and urinary symptoms that women go through, and that will definitely kill any libido. But there are still women sexually active, and that is a vital part, because HRT is not contraception.
Yeah.
HRT will help with symptoms, but it's not contraception.
Yeah. So, yeah, speaking of that, I mean, I did a survey a while back of remember there was a survey that came out that was looking at women's reproductive health between the ages of 16 and 55, and I was so incensed by the fact that it stopped at 55 that I modified it, and I did it for the 55 plus age group, because I thought we still had sex. And the sad thing that actually came back out of that was literally, I think it was, I can't remember the exact figure now, but it was around about 70% of women who had sex within the last 7 days said it was painful. So basically they were having sex with pain, which is really not fun.
No, and that I know that's not today's topic, but that's another very important topic, because women don't tend to disclose that.
No.
They don't talk to their friends about it. I'm always the weird one in a, in a lunch group or a coffee group, and I'll be talking about vaginal pain and urinary symptoms. And I'm of that age now where my peer group are going through those changes, and they're all looking embarrassed. But I think it's such.
Really carefully.
And I'm going, this is really important. This is really important to get it right now, rather than ignore it and let it build up till it gets really severe, and actually becomes a massive problem.
Yeah, absolutely. Very true, especially because there's so many things that are so simple that can really help. But going back to where we were, right, so we've decided we're going on the pill. We've got our HRT. So our options then are for contraception, either a I can't talk today, progesterone only or the Mirena coil. Are they the two main options, or are there others?
And you've got the implant as well. So, the injection is still an option up to the age of 45, I would say. Once you are at 45, we tend to try and get you off the injection, just because I don't think it is as popular contraceptive method as it used to be, because we have other methods that I think are better. But it has an impact on bone density, and it can cause bone thinning or loss of bone density, actually, for some women. Now, it is reversible. It's not for all women, but particularly if there are risk factors already. So if there's a family history of osteoporosis, women perhaps is lower BMI, perhaps has some malabsorption issues with calcium and vitamin D, perhaps on what we call corticosteroid treatment, so needing treatment for other conditions. You're not going to be thinking necessarily adding that as well. And we want to reverse that before the age of 50, because postmenopause is another risk factor for osteoporosis, so another risk factor for affecting bone health. So yes, progesterone only pill, progesterone coil, so it has to be at the right dose, I guess, if you're using it for HRT, but you could use lower dose ones just for contraception. And you've got the progesterone only implant as well.
Okay, so they're three good options. Now, if I have started on HRT, then okay, and I've got my estrogen component, and somebody says to me, okay, well, you're on the progesterone only pill, that's enough, you don't need anything else, your endometrial, your uterus is protected. Are they correct?
That's a good question. So now you put me on the spot here. It's difficult to know, because we have some smaller studies that show that if you double the dose of what we call a desogestrel pill, that potentially could give endometrial protection. But again, they're not studies that we would say, oh, these are large studies that we would definitely want to quote this in our guidelines and our evidence, etc. So at the moment, I would say it's not clear, and we don't know. So we tend to avoid advising that we use, for example, a double desogestrel pill. So the simple answer is no, the pill is not equivalent to a progestogen to provide endometrial protection. So you will still need a progestogen component in your HRT on top of your progestogen only method.
So then I guess the question is, how much do I need on top of that? Especially given the new guidelines out, it's sort of how much progesterone can one koala bear?
Bless. Well, exactly, because the higher you go in your progesterone, the worry is the more likely you could get progestogenic side effects, which you don't want. But if we stick with the recommendations from the British Menopause Society, then the chances are that that's going to be manageable and adequate for avoiding a buildup of high progesterone, because the amount that we actually use isn't as high as we used to take perhaps decades ago for contraceptives. So we have managed to reduce the dosing to a level where it is still effective, but not at such a high level that it's going to cause significant side effects. That's for majority, because obviously there's always going to be women who are sensitive to progestogen who are going to have issues with whatever progestogen method they have. So if you're on a progestogen only pill, you would still be using the same dose of progestogen in HRT as recommended. So let's say it's micronized progesterone that you're on, then you would take the recommended dose that you would take, whether it's sequential or continuous. So you wouldn't change that just because you're on a progestogen only pill. If you are at the implant, same advice. Now, there are variations that specialists do. So we do tweak and adjust things depending on the patient in front of us. But obviously that's a very individual case by case. So I don't want to go into the details of what we can do and adjust, but because we have to look at that person as an individual and decide if we actually need to reduce that progestogen to a point where it's still providing protection. But obviously,
but not
we don't want to over.
Yeah. Other symptoms. Yeah. Sorry.
Yeah, I was going to say with the Mirena, it's a bit different though. So with the implant and the progestogen only pill, we're still using standard HRT at the moment. But with a levonorgestrel coil, that is equivalent to the progestogen. That's sufficient progestogen as part of HRT. So in fact, if you're on a Mirena coil or equivalent, I mean, there are more brands now, that can be your progestogen component. So that's the only exception that we have currently, providing your contraception and your progestogen component for HRT.
And is there a time limit to which you can have a Mirena coil or its other new market equivalents? I've heard some people, I'm reading somewhere sort of no greater than 5 years. And I was thinking, well, that's very unfortunate because I'm well over 5 years.
No greater than 5 years having a Mirena coil. Is that what you? No,
yeah.
no. Oh, no. No, where's that information come from? Absolutely not. No. When I think, I think I know what you mean by the 5 years. It's the endometrial protection. That's the 5 years.
Yeah, something I was reading on studies of, basically, I think most of the studies haven't looked beyond 5 years. But anyway, I digress. So it was sort of like, the studies were showing there was XX and X and XX resulted by it for use for less than 5 years. And I was sort of thinking, well, what does that say then about use for more than 5 years?
So you can have a Mirena coil for more than 5 years, but what you've got to watch is whether you're using it for HRT, then it's only going to provide endometrial protection, so protection for your womb, up to 5 years. So you would need to change the Mirena coil every 5 years if you were using it as an HRT component. If you were using it just purely for contraception, it's now licensed for 8 years. And if you're over 45, then you don't need to change it. You can continue till you're 55 and then have it removed. So it depends whether you're using it for HRT or not.
Yeah.
And in fact, so maybe that's where the 5-year thing came from,
Maybe.
because I love Mirena coils, and I could, go on and on about how wonderful they are if you can tolerate the procedure, because they provide the contraception that you need. They provide, once you get to the point and need HRT, they provide that endometrial protection. But also, they help with heavy menstrual bleeding. So they're a really effective method to help women who are, particularly in perimenopause, when you're having kind of bigger gaps and then heavier menstrual flow. That can help with that as well. And a lot of women then start complaining about flooding, etc. So you have a Mirena that's doing all three.
Yeah. So I guess the thing to remember then is if you started at 45 for contraception, and then if you went on HRT afterwards, you'd have to have it changed sooner.
Yes, yeah, you're meaning if you had the coil fitted at 45.
Yeah, and you've been told you could have it for 10 years for contraception, but then if you
Yes,
have it on your estrogen for HRT,
exactly.
is now less.
Let's say you start your HRT then at 50, then you'll need a new coil, unfortunately.
Yeah. Gosh, what are these things to keep on top of? Now, let us say that we have started HRT, and there are various different forms, as we know. We've got the gel, we've got the patch, we've got the spray, we've got, God, is there anything else?
I'm just trying to think, I know.
I think that there are two different types of gels, a spray and various different types of patches.
Various patches, various orals.
And we go, the tablets. And if we go on them and we find that we have, side effects like sore boobs, our headaches get worse, we're bloating, we're doing all of these sorts of things. How long do you normally say to somebody, let it settle, or let's change, let's either change the type or the dose? How do you manage that?
Yeah, so this is very common, because whether you're starting an HRT or a hormonal contraceptive method, you're bound to have some initial side effects, unfortunately. You are introducing something new to your body's having to adjust. Now, as a general rule, there's no, definitive answer, but as a general rule, we go with 3 months. So really try and see and reassess at the 3-month mark. Now, some women's side effects I've had, particularly with contraceptive pills, settle within a month, and with HRT as well. But others, it can be quite significant and can take a much longer time. So realistically, it's 3 to 6 months for things to settle, particularly if your side effect is with the Mirena coil and bleeding, or a progestogen only pill and bleeding. So bleeding is your main issue. That can take a bit longer to settle. But things like breast tenderness, that should ease. And there are things that we can do if it really gets severe. So particularly headaches, we would need to want to do a quick check and assessment to see if it's still safe, rather than a new onset atypical headache or migraine. But it's we may have to reduce the dose to begin with and go half the lower dose even till you tolerate the hormones, and then slowly increase it. So it may actually take right up to the 6 months to really fully assess where things are with side effects. So normally we would have a 3-month review around that time, if everything seems to be okay, and then assess where we're at. So if there are quite debilitating side effects, as in they've not settled, what do? We need to identify, is it the dose, or which hormone is it? Is it the estrogen or the progestogen? And is it the dose?
Easy to tell how when you would no. Okay.
No, I think sometimes you can classically say, oh, this is estrogenic and this is progestogenic, but quite often they overlap. So, it can be very difficult to tell. And usually you go by the information that what other methods they've had before. So usually in the past, if they've had progestogen only methods, what were they side effects with that? Were they on combined methods? Were they okay with that? So it's more of trying to put the pieces of the puzzle together to identify what could be causing that.
Yeah, very tricky, isn't it? Especially with the progesterone component, I'd probably imagine. But I suppose if they've had a history of PMS or PMDD, then you'd probably sort of look at it and go, okay, maybe it is that side, if it's a mood issue they're suffering from. It's funny, actually, because I never had an issue when I was on the pill with mood, but when I started on progesterone, on Nutrigestin, whoa, that
Yeah.
was horrible. That really was making me really, really moody, really anxious, and reflux.
Oh,
Reflux.
yes. Yeah. Yeah.
Yeah.
Who would have thought it? But yes,
Yeah.
that's one of the symptoms as well.
Yeah. Yeah, so that was it. And yes, so even vaginally, it wasn't great. It was sort of like, didn't matter which orifice I used, it was sort of still.
It was awful.
So back to the Morena yes, interesting. It is such a trial and error too, just to get that right dose, and you find people just not feeling. I guess in some ways they're sold it as a magic
Oh,
pill to
yes.
all of your symptoms
Yeah.
away, which isn't what it's going to do. But then you just, if you start something and you kind of feel worse for the next, 3 to 6 months, you just probably think, why am I bothering?
Absolutely. I agree, because you're thinking of, which badness do I want? Are my menopausal symptoms due or my hormonal side effects? No, it isn't that bad. If a woman presents and she clearly needs HRT, then it is all about tweaking and adjusting that for her and individualizing the dose and the combination. So, as you said, the progestogen maybe is an easy one to trial with, because the estrogen, is estradiol, and that's very similar in all the different HRT methods. But the progestogen one we can change, and then we could trial your estrogestin. You could be getting a synthetic progestogen instead, and that might actually be better for symptom control. Particularly, as you mentioned, this is really important. As I said, putting the pieces of the puzzle together. So, is there a history of PMS? Is there a history of different contraceptive methods and the side effects? If you were fine on a combined pill, but not on a progestogen only pill, or for example, then that gives us indication of which bit is affecting you. But also postnatally, you want to get indication of what symptoms were like in the postnatal period if they had children, and breastfeeding. So that gives us a much clearer picture of what that individual is doing, and how they respond to hormones.
Because estrogen levels drop after pregnancy as well, don't they? So but actually,
Particularly breastfeeding.
yeah. What's your? I've forgotten what's your progesterone doing then?
Oh, that's a good question. So it's it's high during pregnancy, but then I'm just trying to think. It's still there postnatally, but your estrogen. It depends if you're breastfeeding. So if you're breastfeeding, that estrogen is lower, because a lot of women can get vaginal symptoms during breastfeeding. Because I've seen lots of younger postnatal women coming and seeing me with vaginal symptoms, like in the perimenopause or postmenopause, really severe, and needing a bit of vaginal estrogen during that time. But if you don't breastfeed, then your hormones recover very quickly. So it depends, actually. The answer to the question depends whether you're breastfeeding or not. So we know that fertility-wise, really from day 21 postnatally, that you could have fertility again, and therefore your hormones, although they're not 100% kind of back to perhaps a regular cycle, some women are very quick and back again, they go to what they were quickly postnatally, but most women will take a few months to get back into their own kind of regular pattern and allow your own hormones to adjust. But so if you're not breastfeeding, it's much simpler. Your body, adjusts quicker and goes back to normal, what's normal for you. But if you're breastfeeding, then it's a different picture altogether. And then it depends whether you're fully breastfeeding on demand, or whether you are occasionally topping up, and sporadically breastfeeding. Then your hormones, are doing all sorts of different things. So it's not a clear answer. I guess it depends on what you're doing.
Yeah, yeah. Question here, and actually, it's an interesting one. And I'm guessing well, I'll read it to you. Annie. In terms of research done for long-term safety, is there more that has been done on the Mirena coil over Utrogestin? And given that Utrogestin is quite new, and the Mirena coil has been around for quite some time, I would imagine that there was much more on the Mirena coil on long-term safety than there is on Utrogestin. But am I wrong?
The answer is I don't know without looking at all the different studies, because micronized progesterone is now is newer, available and used as HRT, because it's now marketed as being body identical and bioidentical and safer for you, when in fact actually it's not, doesn't suit everybody. And it can cause lots
as well, so it's not systemic, so there's very little systemic from the coil.
Yes, so I think was the question about how much data and evidence there is about looking at the different ones. We know from the Mirena, we have lots of studies, because we don't just use it for contraception, we use it for gynecological conditions as well, etc. So we have lots of data about that. We may actually, in fact, have more data for micronized progesterone, so I would need to look into that in more detail to see how far back we've got information, because we use micronized progesterone for other things as well. So they use it for, you may use it for fertility management. So different dosaging, different ways that you would use it. So again, it's something that may have been around, but just it's not been used for HRT that long. So when we're looking at it from an HRT perspective, we have data on it, we have good data on it, but how much in comparison to Mirena, I don't know. I would need to do a proper research study on that.
Yeah, and I guess with the other uses as well, I mean, some of them will be short-term as opposed to sort of long-term continuous use, and it is a whole new area, and this is why we need much more research. This is exactly
well, it's exactly. I mean, I think micronized progesterone. I think we need a lot more research on it. What I would like to see is a lot more information about it on breast cancer risks, etc.
Yeah.
So
that's what we're asking about safety. That's probably mostly what people are asking. Yeah.
Because it's reported as being natural, but that doesn't mean it's not a hormone that you're taking. And yes, the risk is lower from the studies that we have for breast cancer compared to other, to synthetic progestogens, perhaps not all of them, but so I think we need more research on that to identify, and also what I'd like to know is more information about cardiovascular health and cognitive health and dementia risk, etc. Because again, our studies that we have on dementia, it's like we don't know what we're looking at. We don't have that information. Some studies say yay, some studies say nay, that kind of thing. So these are very good questions where we need a lot more research on.
Yeah, absolutely, 100%. Is there? I'm just looking at my little list of questions over here. We've done the common side effects. We've done the settling times. We've done. Is there anything else that we need to cover, or do we think we've covered contraception?
I'm trying to think if there's anything else. I think we've talked a bit about the methods. We've talked about when to stop contraception when you no longer need it. We've talked about using contraception as an HRT component when that's possible, when that isn't. And we've talked a little bit about HRT and when you should start it. The only thing I didn't mention, which I'm sure it comes up in other topics anyway, is the question is, when should you start it, and therefore how long should you continue it, and then when should you stop it? So my answer is, look, assess those three things: the age, how severe your symptoms are, and how is it affected sort of in your menstrual cycle, and then decide if that HRT is there to help you with your symptoms so you can function. And then don't worry about how long you then need to be on it, because we then will reassess it, ideally annually, to decide at what point it's worth coming off it. So I think if your symptoms are that bad that you need HRT, then, you know, don't be put off starting the HRT and think, oh, I'll just start it at 52, but my symptoms are really bad age 47. Well, use the HRT now.
No,
and then
5 years unnecessarily.
and
Yeah.
if you happen to be on HRT for longer than 5 years, you know, that's what you need. You know, again, I get a lot of women who get told by a healthcare professional, well, you've been on HRT for 5 years, that's it, you're now coming off it. Well,
Over my dead body.
it may be relevant. It may be relevant, yes, for that individual to wean themselves off. But again, it's like the contraceptive pill. You're not suddenly going to stop it from one day to the next. I think that's a bit unkind. You may be fine, but you might not. So I tend to say it's probably kinder just to wean yourself off it slowly. But you know, you don't need to stop it because there's still a significant proportion of women that have long-term symptoms.
Absolutely. I think what they say now is that, you know, as long as your health is fine, you can continue on. It's a general message.
Yes.
Isn't it?
Yeah.
And the other, as mentioning though, this is the other thing that came out of my post-55 reproductive health study, was that the symptoms were going on, and that actually wasn't the vasomotor ones that were the problem. It was the insomnia, it was the brain fog, it was the low mood and depression, and the vaginal symptoms and the urinary tract ones. They just did not stop. It was around about 70 to 80% of people had those. The night sweats might have gone down a little bit to about 30 or 40%, I think, and the hot flushes, but the rest of them were just ploughing on like no tomorrow. But nobody talks about those. We still have this narrow focus of sort of like menopause has to be about irregular periods and vasomotor symptoms, but it's so much more.
Absolutely. There's an endless list of symptoms that are classical, but also there are non-classical. I mean, the most interesting one I had, which I found very difficult to kind of comprehend myself, but I had a lady with plantar fasciitis, which is, you know, inflammation of a part of the foot at the bottom, which can be quite severe and painful. But she started HRT and it disappeared. And I thought, you're the first one, you're the only one I've ever had with that. But we started HRT for other reasons, but it turned out that seemed to also alleviate. I don't know if that was coincidence because, you know, she may have rested her foot or seen a physio without me knowing and sorted that out. But she was adamant it resolved. The other thing to add, Fiona, about when I was saying about HRT, being able to continue that on, you can continue the HRT. The contraceptive component, as I said, no longer is required after 55. But if you're using that Mirena coil, then for your HRT, some women may want to continue that Mirena coil for the HRT component. So you can get women, not that I would recommend it highly in your 60s, having a Mirena coil, because it becomes more difficult. The procedure, I would say, as you get older to change the coil, but it still may be the best method for that individual. And the other thing to add on that's not contraceptive related, but as you mentioned, vaginal urinary problems continuing on, not to overlook the vaginal estrogen. So that you know, if you've got significant symptoms, that never should stop. That is indefinite.
Yep, that's for life, that one. Absolutely. True. Brilliant. Excellent. Well, I think we've pretty much covered all of it. And when I say over my dead body, I mean only over my dead body, not over anything.
Well, depends on your day and your mood.
The best one. Brilliant. All right. Now, if people want to find you, where do they find you?
That's a very good question. I get asked this all the time. And so this is quite a challenge for me at the moment because I haven't secured a location yet. But the best way to contact me is through the Menopause Consortium for anything women's hormonal health. and they will then direct your queries to me, etc. So that is the best way to contact me with regards to women's hormonal health. I also do work with Heal Health, which is actually through pharmacies. So that is if you happen to pop into a pharmacy who is associated with Heal, then you can get access straight to a specialist like me for support and help. But
and how do you know if a pharmacist is associated with Heal? Because I did not know that.
At the moment, it would be where you would have to ask your pharmacy. Not every, obviously, we're not in every pharmacy. You could either contact Heal directly, and then ask. We direct you straight to a pharmacist. Or if you happen to see signs up in your local pharmacy, so there's various ones in London at the moment that have signs up and posters showing that. But again, you'd have to look quite closely in the windows, etc. The easiest thing is just to contact the Heal information, and we'll direct you to your pharmacist. So that's one way. So we have pharmacists available to manage menopause and then direct access to specialists. And then with TMC, you've got direct access to women's hormonal health overall. So it's not just menopause that TMC provide. We offer things with PMS as well as PCOS. So anything what I consider community gynae related as well. And if you have the sexual health problems. So we have a very experienced doctor, Dr. Joe, who deals with psychosexual problems, etc. We have a psychotherapist, we've got a dietitian. So there's lots of different components, and not just me, but it's either through Heal or TMC that you would get in touch with me until eventually I have a place where I can see patients face to face.
Brilliant. Excellent. Well, look, thank you so much for that. And hopefully we will speak again in the future. I shall now end this over here on this one and end it here on the other one as well. I've got too many things to go on that go on in life, but thank you. And I will speak to you soon.
Thank you very much, Fiona, for giving me this time to do that.